in multiple book chapters, editorials, about 89 abstracts that I could see, and all of them were very impressive. Currently, in addition to doing the full clinical aspects of vascular surgery, endovascular therapy, has a robust research interest, and right now really focusing on improving clinical cost-effective outcomes for patients with claudication, non-healing ulcers, and chronic arterial ischemia, with a big focus on quality improvement and a system-based approach. So there's a lot more I could say, but Dr. Barshes, really appreciate this talk.
Thank you, Josh. I had a chance to meet and work with Josh in Boston. I appreciate the chance to talk with you guys and talk with you about this topic. It's a big topic, I'm sure you guys know, and a lot to cover in, I'll try to keep it to about 40 minutes or so. Hopefully we'll keep it concise, but hopefully it'll give some kind of, mainly a framework on how to approach people with peripheral arterial disease, and when to make decisions on treatment, how to treat. So here's basically some topics, and two, I'd encourage anybody to either type in, if you do want to ask questions during the presentation, please feel free to do so, type them in, or I guess talk if you're connected by phone, so we can talk about any of these issues that need further clarification. But just a few topics to discuss. First, acute limb ischemia, chronic limb ischemia, the main categories within chronic limb ischemia and critical limb ischemia are things that we'll go through. Here's my caveat. This is the talk is. I'm sure you guys in the audience know about the techniques for treatment. The focus of this talk, at least the intention given this talk, is to focus more on the pre-intervention evaluation, management before and after. So it's not so much to focus. I really won't focus much at all about the technique. Maybe some outcomes-related things related to specific techniques, but not how to do any particular technique, because again, I know you guys know about that. I guess the other disclaimer is that I am a surgeon, so the I try to approach things. I do endovascular intervention as well as open surgical intervention, but some of the talk is the talk is from a surgeon perspective, and I talk about open alternatives also for some endovascular interventions. First main category, just to talk about acute limb ischemia. The recognition of this problem is usually pretty clear clinically, and usually the diagnosis of this is made really from the history, and if not the physical exam, most of the time confirms that it's an acute problem. Generally, these patients come in with the 6 Ps that we all learn in medical school, and the difference is there's some overlap between some of these symptoms and people who have chronic problems, pain in particular. A lot of these do overlap, but the main difference is the very clear acuity of the onset. Most often, the patients can give you a specific hour where the onset of the symptoms occurred. There can be some overlap, and people with some degree of chronic disease can present with acute problems. But for the most part, it actually occurs in patients who are relatively asymptomatic, and then, like I said, have a pretty abrupt and pretty significant change in their clinical condition. Acute onset of pain, pallor, paresthesias, paralysis, poikilothermia, pulselessness. Again, those are the typical 6 Ps. This is a photo of somebody who presented at our med center with acute limb ischemia. Some of the notable findings here: cyanosis. This patient did have some degree of motor impairment and some decreased sensation as well. If you see a patient like this and see controls for the IR suite in the background, then you know you're in trouble. It definitely confirms the diagnosis. But like I said, for the most part, it's mostly based on his history and physical. In terms of etiologies, the reason why a lot of patients are previously asymptomatic before they present with this problem, a lot of it has to do with embolic disease. A lot of these are patients with atrial fibrillation. You know, the typical situation, a very common clinical situation at least, is an 80-year-old patient who has chronic atrial fibrillation, had been taken off of Coumadin because of fall or being thought to be at high risk for a fall or some other reason, and then presents with at some point down the road, acute limb ischemia, upper extremity, lower extremity, acute mesenteric ischemia also is something that can occur. So embolic problems in general, the most common etiology, and cardiogenic specifically, the most common source of emboli. There are some non-cardiac causes to talk about, ulcerative plaques, mural thrombi, those are less common. The patients who sometimes have some baseline chronic vascular symptoms are more often the patients that present with acute limb ischemia from a thrombotic cause. And most of these patients, for the most part, I would submit, are patients who have had previous bypasses and specifically two prosthetic bypasses in the past. They may have some background claudication with the graft open, but then once the graft occludes, they may present with rest pain. They may present with clear acute limb ischemia with again the 6 Ps. This is not an uncommon situation at all. It can happen in people who have high-grade disease of native arteries, high-grade atherosclerotic lesions. It doesn't seem quite as common. And then other rare etiologies are even less common still, things like popliteal entrapment syndrome, adventitial cystic disease. These are very rare entities, really only worth mentioning, that's it. Again, this just kind of talks about cardiogenic emboli, and another way to recognize that the etiology is embolic and that it's cardiogenic specifically is because these emboli typically lodge at the within larger vessels or within branch points of larger vessels. They typically do not embolize to digits. They typically stay in the upper extremity, typically at the brachial bifurcation. That's a very common place to see it. In the lower extremities, either at the aortic bifurcation, within the iliac system, in the common femoral, right at the branch point between the deep femoral and the superficial femoral, very common. And when these are taken out too, they very often too have, and I don't have a good picture on this, unfortunately, but they very often are well organized. They have a fibrotic appearing cap, and then they also have, along with it, some softer thrombus. Management for patients with acute limb ischemia, obviously when it is seen and recognized, patients should be heparinized unless there's some compelling contraindication against it, specifically heparin bolus, weight-based bolus, and then a drip. Usually, for the most part, I think most people use heparin specifically because, for the most part, these patients are going for some kind of intervention, and having the shorter half-life of heparin is helpful to manage the anticoagulation around the time of that intervention. And just to make mention again, we're not going to go through technique so much, but just to mention some of the options. For surgical options, the standard for acute limb ischemia before the advent of endovascular techniques to deal with this was Fogarty thromboembolectomy. Let me just see if I have a picture. I do have a picture of it. So essentially, it's like a PTA balloon, and you guys may have seen this as well. Basically, open access to the vessel and arteriotomy, and then passage of this balloon through the vessel to just manually extract clot. The endovascular options for this problem, again, I'm sure you guys are familiar with. We won't go into detail of that. The one thing that I will point out to look for afterwards in somebody who has pretty severe and especially pretty abrupt onset of ischemia, always just be attuned to the development of compartment syndrome afterwards. More often occurs in people who have had prolonged ischemia. There's no one set threshold to say when somebody's really at risk for developing it. We kind of typically say about 6 hours of ischemia puts somebody at risk for compartment syndrome afterwards, but it could be shorter, or alternatively, people can go longer if they, especially if they have some degree of chronic disease at baseline. It seems like they can go longer and not develop compartment syndrome. But afterwards, the typical clinical scenario is somebody who initially gets some good relief of their symptoms, resolution or at least improvement of paresthesia and motor function, and then within a few hours after that worsens. And then this is something that's addressed with fasciotomy, four-compartment fasciotomy in the leg. The next topic, before we go on, next topic was going to be claudication. Any questions, anything else that people want to go through related to acute limb ischemia? I don't see no questions coming up on the chat, and I don't hear anything. Chronic limb ischemia there's more to talk about here, so I think it'd be good to, focus a little bit more time here. And first, people with claudication. Claudication, by and large, is what I think most people will see in the clinic. This is really the bread and butter. This is routine in vascular surgery. In our vascular surgery clinic, this is the single most common thing that we see in our clinic. And I guess to back up too, the title of the talk is Peripheral Arterial Disease. That specifically refers to anybody with an ABI of 0.9 or less. So most of those are asymptomatic. So only about of the patients with peripheral arterial disease that are symptomatic, most have claudication, but it's only about, there's a range of estimates, but it's probably on the order of 10 to maybe 20% of people with peripheral arterial disease that are symptomatic, and most often symptomatic with claudication. What is claudication? Again, this is something that I'm sure most of you all know, but there are, the one thing that I want to point out in this is things that help differentiate it from other etiologies. First, it is akin, the easiest way to think about it is being similar to exertional angina. Basically, demand for oxygen in the muscular beds of the lower extremity outstrip the supply. So it is, like exertional angina, something that causes pain. The classic presentation for claudication, we look for three things. One, it's universally reproducible, meaning that patients will tell you, I walk 100 feet and then I get pain, and it's always 100 feet. It may be a little bit shorter if people are walking up an incline or upstairs, but it's pretty consistent in the distance, or at least the time or effort. And I guess that's in distinction to people with some degree of osteoarthritis, where they may say they have good days and bad days. So that's one characteristic that is important to note. Second thing is that it's relieved by rest. And specifically, patients with vascular claudication don't necessarily need to sit down, whereas people with lower back pain, radiculopathy, and other back problems, typically, and spinal stenosis specifically too, typically say that they have to sit in order to get relief. and two, patients with some of these problems will very often be able to walk much further if they're leaning over. The classic thing is leaning over on a shopping cart and being able to walk indefinitely when doing so. And then the other thing is muscular location. It is, like I alluded to earlier, it is located in a muscular bed and is usually specifically in the calf or in the thigh, and that is another typical symptom. So again, these are things that we look for. These are things that definitely increase the likelihood that patients have claudication symptoms from a vascular etiology. That being said, there is a lot of overlap, as you would imagine. There's a lot of people who have peripheral arterial disease, impaired ABIs, symptoms that sound pretty suggestive of a vascular etiology of claudication, but they may also have some component of osteoarthritis or may also have some component of lower back problems that is contributing. So it can be somewhat difficult to sort out what is definitely from vascular etiology, what is likely from the vascular etiology, how much a patient may improve with addressing the vascular component, which should be addressed first or at all. Should the vascular component be addressed only? Should it be done only after a lower back procedure if they get no relief? That can take some judgment, and there's no clear, there's no objective tests that can really make that decision very based on much data, let's say, but it's something that can be challenging. First-line therapy for somebody with claudication is exercise. And exercise therapy for patients with claudication is actually one of the most well-researched topics that we have in our field. It's something that's been looked at over the course of several decades, and very consistently. It's been compared to bypass operations, and it's been compared to endovascular interventions. And hopefully you all have heard most recently of this CLEVER trial, CLEVER an acronym for this recent trial comparing exercise therapy to endovascular intervention. For the most part, exercise therapy wins every time. There's some trials that suggest that endovascular intervention may be a good alternative, but for the most part, exercise therapy is at least as good as intervention. And for that reason, most of the medical specialties that treat patients with claudication have recommended exercise as first-line therapy for most patients with claudication. Our Vascular Surgery Society, ACC, AHA are all in line with that. And typically, patients will more or less double the distance that they're able to walk or the time that they're able to walk if they do follow an exercise regimen. What we typically do, there's no real clear standard on what comprises a good exercise regimen, but what we typically do in our clinic is recommend that they walk at least 3 to 4 times a week or more if they can, and they start out walking about 20 minutes a day and then building up from there. And then we specifically tell them that they get to the point of getting their claudication pains, and then they walk a little bit further before they stop and take a break, and then repeat that same cycle again. Basically what this is doing, I think I have a slide that talks about why this may actually improve the ability of a claudicant to walk. What it doesn't do is it does not change the macrovascular blood supply to the legs. That's been shown pretty consistently. There's no change in ABIs. If it's doing anything at all to the blood supply to the legs, it is in the capillary level blood supply. There also is a change in the, it's almost like anaerobic training for athletes. There's a change in the balance between slow twitch and fast twitch muscles, and basically a tolerance for local acidemia from lactic acidosis. So basically, patients get more tolerant to the anaerobic metabolism and the symptoms that they get as a result of their peripheral arterial disease. Smoking cessation is another important component, and we spend a lot of time in our clinic talking to patients about smoking cessation. It's important really for their overall health to decrease their risk of, and this has been shown again repeatedly in several large studies and randomized trials, to reduce the risk of cerebrovascular events and coronary events. It's not really clear that it actually improves or decreases the incidence of limb events, but there's some data that suggests that it may at least decrease the progression to rest pain, so it may have some benefit. But regardless, it is something that we urge, and it's an important component of the care of patients with claudication. I see one question. I see there's one question about acute limb ischemia that came up that maybe we'll go back to at the end, related to exercising decreasing mortality rates. Another question that somebody put up. It does, and again, mainly through its effect on cerebrovascular and coronary events. About 75% of the deaths that occur in this patient population are from those events, and it does have, exercise does decrease the incidence of those events. I don't believe it's a very strong treatment effect, but it does have some impact on survival. ABIs, you guys may use in your clinics and on the inpatient wards. ABIs can be helpful to, again, corroborate the fact that the patient's claudication symptoms are from a vascular etiology. And again, somebody with non-palpable pulses, it may be very clear, but in patients who maybe either have what you think are weakly palpable pulses or other etiologies that may be playing a part, ABIs can be helpful. And then if people do seem to be candidates for intervention, if they seem like they would benefit from intervention, then it can be helpful in level selection, helping identify what is the level to focus on for treatment. Again, I guess it's used in conjunction with the physical exam, but this is something that can be helpful to guide treatment. For the purposes of time, maybe we shouldn't talk too much about level selection based on ABIs, but we'll just go on from there. Just a little bit more about just medical management. This is some of the inter-society guidelines that I was referring to. I think this is the most recent installment from 2010. The original, the more robust, the more complete guidelines, I think were from about 2005 or 2006. And it's a great reference to go through. In essence, I'll boil it down to a few main things. Aspirin for pretty much everybody, unless they have a very strong contraindication to it. And this is something that has a very large impact on, treatment effect on decreasing mortality rate in this patient population. Beta blockers as well. There's some evidence for ACE inhibitors for this patient population, but obviously treating hypertension and decreasing mortality by doing so. Cholesterol-lowering medications and diabetes regimens for patients who are diabetic. The treatment goals for cholesterol are in the guidelines. There's recommendations on smoking cessation. It's a pretty good document overall, and I'd recommend that if you develop a practice where you're seeing a lot of these patients, it's worth going through. The way that we do it in our clinic is we see a high volume of patients in our clinic. We don't take it upon ourselves to be the main person managing hypertension, cholesterol. and ensuring that they're on an aspirin. We look for those things when they come in to see us. If they're not on those things, we tell the patient to kind of co-manage their comorbidities and their risk factors with their primary care provider. And then we make very clear recommendations to the primary care provider in our medical chart so they can follow up on those things. We feel it's important to have both the primary care provider and the patient involved in modifying those risk factors because those are really the patients, the stakeholders, if you will, that are really involved in long-term care and decreasing mortality. So now in terms of intervention, if someone has tried first-line therapy, exercise therapy, and has failed, meaning that they have stuck with it and maybe they've experienced some improvement, but their symptoms are still impairing their ability to either work or do their typical daily activities, then they should be considered candidates for intervention. I'll say this, the indications for intervening on somebody or what constitutes a failure of medical management for claudication is not very clear. There are no consensus guidelines for it. There's no agreement within the literature among vascular surgeons, among interventional cardiologists. I'm sure in interventional radiology, there's no real clear definition of who merits, who has failed exercise therapy and who merits an intervention. But for the most part, we just kind of say, like I mentioned, people who really have very severe symptoms that limit their ability to do daily activities, and especially people who are working and feel limited in their ability to work because of these symptoms. So if a patient is thought to meet that indication, figuring out what to do is next. And in contrast to some of the patients that we'll talk about in a little bit, patients with rest pain and especially patients with tissue loss, for patients with claudication, the surgical mantra for quite a while has been to address single level disease only, at least at one setting. And most of these patients, because of the comorbidities that they have, the incidence of inflow disease, specifically aorta, iliac, and common femoral profunda disease, is very high. So that's the first goal, is to look for iliac disease, look for common femoral disease, and then treat that. This is somewhat older, but even still, surgical literature is based on, prior to the advent of endovascular techniques to treat this, has demonstrated that treating just one level, treating the inflow, will improve or resolve symptoms in most patients, on the order of 85%. And I think the endovascular experience has been very similar. I think at least as good. So that is one key take-home point, is in terms of intervening on claudicants, is to really focus on inflow and address just one level at a time. Now there are patients who, not as common, but patients who have no significant disease in their aorta-iliac system, common femoral, and have just isolated SFA disease. In those patients, obviously, too, treating that level is worthwhile. If they have SFA disease and some tibial level disease, typically what most of us would do would be to focus on the SFA and not necessarily feel compelled to treat multi-level disease for a claudicant. At least not in that first initial round of treatment. There is always the option to go back and treat further if the patients don't develop a good response for that initial round. treatment. So question from someone regarding a trial period of exercise prior to intervention. Yeah, great question. And again, I think there's a pretty wide range of, there's a lot of heterogeneity in practices, and I would submit that very few places have an explicit protocol where they say somebody's had to try exercise therapy for this long before having an intervention. There's a lot of heterogeneity within centers. I think there's even a lot of heterogeneity within providers. I know sometimes it seems kind of haphazard on when some people get some interventions and other people who may seem to have severity of symptoms that is similar don't get an intervention. So the short answer is no. There's no clear trial period, and even in terms of what constitutes adherence to exercise therapy. You know, if they're walking twice a week, 20 minutes at a time, is that good enough? Should they try further? There's no real clear consensus on this. Related to smoking cessation too, some places do and some providers do have I guess you call it a rule that they won't treat a claudicant who is actively smoking. Some people are on the opposite end of the spectrum and just treat regardless. Some people at least look for some improvement, some efforts to at least cut down, and a patient who has the goal of quitting completely before they would undertake an intervention. These are things that, again, are not really clear. There's some very clear data that smoking does impair the durability of bypasses. The data, the impact of active smoking on endovascular interventions, I've actually looked for it. There's not quite as much out there on it, but there may be, it looks like there probably is some negative impact on the durability of endovascular interventions as well. So that too is something to consider. Would, in your practice down the road, are you going to require that patients at least make some efforts, or require that they stop smoking completely? Again, this is not really clear. And then a couple other questions for home therapy, monitoring therapy for exercise. That too, there's no great way to document how often people are complying or adhering to an exercise regimen. People have, some people, and we're starting to get into this too, some people have used pedometers to quantify how often people walk, or at least to look at trends in steps taken. That is something that may be helpful, but I guess, again, the short answer is no. There's no real clear consensus on how to, what constitutes adherence, how much walking is enough, how to monitor walking. That's a big question mark out there. In terms of making the decision between endovascular and surgical therapy, what is out there in terms of the consensus guidelines, the consensus recommendations? Currently, it is based on this task classification, but I think for the most part, I think pretty much all aortoiliac lesions currently are treated. I think that among vascular surgeons, among other interventionalists, I think this is true. I think everybody's approaching these endo first line for most patients. There may be some exceptions. The recommendation out there is for task A and B to treat endo, and C and D to treat surgery, and this is based on the guidelines that are out there from 2007. But like I said, I think I can say for sure in our medical center, and I think in most medical centers, people are at least trying endovascular recanalization for aortoiliac disease for first-line treatment. How good is open surgery for this problem, for aortoiliac disease specifically? How good is endovascular intervention? They're both pretty good. In terms of the interventions that we do in vascular surgery, an aortoiliac bypass is pretty much as good as it gets in terms of durability, in terms of patency specifically. That being said, it's a big operation. It's a big whack, as we call it. It's a big recovery time for a patient. It's an invasive procedure. It's a big incision, abdominal incision, and 2 groin incisions. So that's the downside. A not insignificant perioperative mortality, but pretty good, as you can see on this graph here. The AFB or ABF is the top line here. Durability is pretty good. Patency is pretty good. I guess this graph measures freedom from revision. Now, endovascular intervention is not quite as high, but it's pretty good too. And I would submit to you as well that in terms of endovascular interventions, it's pretty much as good as it gets for treating lower extremity disease. The obvious upside to endovascular intervention is that it is a lower mortality rate, lower morbidity, quicker recovery, likely lower cost, although there's not great cost data that's out there, and fewer complications. So you can see that some of the complications that are listed here, complications from the open AVF, are not insignificant. The infection rate refers to all infections, not graft infection is quite low. Infections overall, pneumonia, UTI, surgical site infection, overall is not insignificant. Groin lymphoceles, seromas in the groin incisions, need for emergent reoperations, not insignificant. So the ABF is a good operation, but angioplasty and stenting for iliac disease, again, regardless of task classification, is first-line therapy for pretty good reason. The Dartmouth Special is a term that I think a lot of people use to refer to the combination of a common femoral endarterectomy, profundaplasty, which is essentially a endarterectomy of the profunda femoris artery, deep femoral artery, and then a patch angioplasty, and that just refers to use of a bovine pericardial patch to close the artery and increase the caliber of the lumen. The combination of that plus retrograde iliac stenting, either with bare metal stents or with stent grafts, covered stents, is also a very good option. And it's called the Dartmouth Special because it's the Dartmouth group that's really published the largest series and some of the best description of outcomes for this combination. But the outcomes overall are very good. Technical success rates that they report are very good, and there are some tips and tricks that we won't go through in terms of recanalizing completely occluded iliacs, options that are available that are either purely endovascular or can be used in conjunction with the common femoral endarterectomy. But the overall success rate is very good. 92% of patients in this series clinically improved, pretty significant improvement in ABIs and a relatively short, at least median, hospital length of stay. A question here about covered iliac stents compared to ABF. Great question. And these guys have published on their experience with covered stents versus bare metal stents in the setting of, I think their data is in the setting of doing it in conjunction with common femoral endarterectomy. But I know they do it as well, and most centers, we do it as well as a purely endovascular intervention in people who don't have significant common femoral disease. And there is some suggestion that covered stents may be better than bare metal stents for patients with iliac disease. This is their graph, and you can see that there is what looks like a pretty significant difference between this. How do they have it here? They have. I don't have the legend, but let me just see if I have the. here, this is the comparison between bare metal stents and stent grafts. Top line here being stent graft, and bottom line being bare metal stents. And they used a variety of both bare metal stents and stent grafts. It seems like a pretty big difference. Not a huge group, and it seems like they don't have great follow-up at the longer time periods for the patients in the stent graft group. But at least early on, it seems like there is a pretty significant, pretty compelling difference between the groups. So yes, there does seem to be some pretty good quality data out there that covered stents may be better for iliac disease. This is just more about re-interventions. The re-interventions are needed for these patients, but most of them can be done with further percutaneous endovascular re-intervention with good results. Role of common femoral endoartery. They did, in their data, they did suggest that there were better results, better patency of the iliac system when it was done in conjunction with a common femoral endarterectomy. What to make of this, I don't know, because these were obviously selected patients. This is not a randomized comparison. So what exactly this means in practice, I don't know. Here's just a picture of just a thick plaque in a common femoral artery in endarterectomy, and basically what that looks like. After seeing how thick and how nasty some of these plaques can be when you shell them out, it's actually surprising to me that stents, especially self-expanding stents, it's surprising that they work as well as they do, but they do work. That's what it looks like. The role of the profunda femoris. So in patients who have infrainguinal disease, patients who either have good inflow, no significance, common femoral or iliac disease, or people who have had disease of those levels addressed, but still have problems walking, have an occluded SFA. What to do next is, I think, another question mark, I think, an area of uncertainty within our field. And there's a few different schools of thought, a few different approaches. I think more and more people are on board with SFA endovascular intervention. And just as another tangent, whereas I think most people are primarily stenting iliacs now, whether stenotic or occluded, there's not quite as convincing data that stenting for the SFA would be beneficial over angioplasty alone. But in general, endovascular interventions are more and more often used for people with infrainguinal disease, SFA disease. If that doesn't work, or if it doesn't seem like it's a good option because of anatomic factors, maybe popliteal disease, then a bypass is often used, and bypass with autogenous vein, greater saphenous vein, can have some pretty good outcomes long term. But that too comes with the cost of it being an invasive procedure. So another alternative is really focusing on the profunda and doing, really ensuring that flow to the profunda is as optimized as possible. And this is just a really interesting series that's out there. This is not randomized, but basically a group that compared their results with a focused profundoplasty, common femoral endarterectomy, versus a fem-pop bypass. And patients who had the profundoplasty do pretty much just as well clinically. The subjective symptoms and their ability to walk is pretty much just as good, even though they still carry on with an occluded SFA. So for a claudicant, a patent SFA is really a luxury. It is absolutely not needed for the most part for patients to be able to walk decent distances without significant pain. Again, there are exceptions. There are people with isolated SFA disease that can be an impairment, but for the most part, addressing inflow disease, maximizing flow to the profunda can have very good outcomes. Any questions before going on to rest pain and tissue loss? Any questions about claudication? All right, nothing else coming up. So we'll talk a little bit about critical limb ischemia a little bit. So now critical limb ischemia, this term critical limb ischemia or CLI basically refers to a couple different subgroups. And that is rest pain and non-healing wounds, or what we call tissue loss. Rest pain specifically, rest pain that has gone on for at least 6 weeks, rest pain that is not relieved by narcotic medications, and rest pain that is obviously, it seems plausible that it's due to vascular etiology. It's associated with impaired ABIs, and there has been numbers that have been specifically put out there. These numbers are from that task, from this task document. So that's rest pain. Non-healing wounds or tissue loss, this group of patients with what we call tissue loss. Tissue loss is kind of an umbrella term to refer to patients with ulcers that are non-healing, gangrene, digital gangrene. It's really a kind of heterogeneous group of patients that have some skin breakdown that has failed to heal with conservative management, local wound care, for at least 6 weeks, and is also associated with impaired ABIs. And there are also, these numbers are also from the task classification. People don't really, in terms of identifying patients or giving patients the diagnosis of having rest pain or tissue loss, people don't really use these numbers clinically very often, but they are out there for whatever they're worth. Just to talk about the natural history of patients who have CLI and don't have treatment, the best numbers that are out there are for patients who have tissue loss, and there's fewer and fewer people out there who don't undergo intervention, but there are some small series that describe patients who either refuse intervention, not thought to be good candidates for intervention because of comorbidities or something else. What happens to them? And basically, the ulcer healing rate, the spontaneous rate of ulcer healing, is actually maybe surprisingly high. It's about 50% within 1 year. You would think that with very impaired ABIs, these are patients who not infrequently have toe pressures in the 30s, ankle pressures, ABIs that are 0.4. Why would they heal? They do heal spontaneously with local wound care, not infrequently. The problem is the recurrence rate is high, and overall the major amputation rate is high. So even though about half will heal, the recurrence rate has been estimated to be on the order of 60%, and the major amputation rate of the people who don't heal is high. Overall limb salvage rates, limb salvage referring to the proportion of people alive at a given point in time who have not undergone an amputation at the level of the ankle or above. The limb salvage rates are low at 5 years. So the natural history is pretty poor, and that's one of the main arguments for treating these patients pretty aggressively. This is this is kind of bread and butter. A patient that presented to our clinic with an ulcer. This is a diabetic man. He has neuropathy in his foot. He also has no palpable pedal pulses. He has peripheral arterial disease. Basically presented with this ulcer, and he kind of typifies too a very frequent history of a diabetic guy like him. Had previously had an ulcer that was treated by the podiatrist with offloading. He had a custom insole fit to his shoe, which kind of took pressure off this area. It actually healed up, but then it recurred down the road, and in spite of further local wound care, it failed to heal. Here's some other manifestations of chronic limb ischemia or critical limb ischemia: dry gangrene of the toes, non-healing wound after a minor amputation, some signs of some non-intact skin barrier or failure to heal that occurs as a combination of multiple factors. And I'll go through some of those factors shortly. This is just another manifestation. Infection, we'll talk about infection briefly, but we'll do that shortly. Foot ulcers, let me just say in brief that foot ulcers have a big clinical impact on patients, especially patients with diabetes, but also some patients without diabetes who have peripheral arterial disease. The burden of diabetes in our country has really reached epidemic proportions, and so I think we're all going to be seeing a lot more of these patients in the future. And why does this have a big impact? A lot of patients with diabetes will at some point develop a foot ulcer. Most amputations that occur in this country occur in diabetics, and especially most of them occur in diabetics who have a foot ulcer. The ulcer is most often the preceding event prior to a significant diabetic foot infection that leads to a major amputation. And amputation of all the bad, there's a lot of bad things that happen to diabetics: blindness, end-stage renal disease. Amputation actually has the largest negative impact on quality of life. And this is from a very large patient series from the UK on the order of, I think it was on the order of a few tens of thousands of patients that rated their quality of life. Huge economic burden as well, and just in the interest of time, I'll just say that this is a really costly problem. So there's a lot of people that are really focusing on trying to avoid or at least manage diabetic foot ulcers when they do occur. In the interest of time, too, let me just skip over the pathophysiology. And again, focus on. We'll just talk a little bit of time. Spend a little bit of time about talking about pathophysiology. And again, I just want to stress that the ulcer is really the sentinel event. There's a lot of things that contribute to the development of a foot ulcer. Neuropathy is definitely a very important one. Some of the structural foot abnormalities that are common among diabetics is another thing. And then the incidence of peripheral arterial disease is the third most important thing. And the reason why this leads to bad problems and limb loss in this patient population, it's just these things: non-intact skin barrier that acts as the portal of entry for bacteria. That plus the impaired immune response plus neuropathy leads to local and eventually systemic sepsis. And this has been deemed the stairway to amputation. And it is, in most patients, not every patient proceeds in an orderly way up the stairway. But again, ulceration is definitely the most common sentinel event. It's kind of the gateway to infection and amputation. And there's some numbers that estimate the risk of progression once some of these problems do occur, and once people do have an ulcer, the risk of amputation is high. And this is just an example of a bad diabetic foot infection. That is one that kind of presented more with gangrene. This is one that a patient who had a gangrenous toe that acted as, was chronic for quite a while and didn't really cause any significant problems, but at some point did act as the portal of entry for bacteria, and then a foot abscess in the plantar aspect of the foot. You can see some of the erythema, and there's a lot of fluctuance in this patient's foot. Not all these patients do develop tenderness because of neuropathy. In the interest of time, let me skip over some of the presenting signs, other presenting signs for infection. Some of the other things that may look like non-healing wounds due to arterial etiology, the main one is chronic venous insufficiency. There's some important differences. Mainly some of the Other findings that you'll see on exam are different. Patients with venous disease will have a swollen leg. They may have bounding palpable pulses in the foot. They less frequently have the comorbidities that you would expect to see in somebody with an arterial ulcer. And they usually occur, they almost always occur in a different area, in the so-called gator area of the leg. These are typically not in the foot, not in the weight-bearing plantar aspect of the foot. These are usually in the leg, and that's because of that is where some of the perforating veins that communicate between the superficial and deep venous systems are. Dermatoliposclerosis is another finding that will help you differentiate between venous disease and arterial disease, but that is probably the most common thing that looks like arterial non-healing wounds. That being said, there are people who have both arterial problems and venous problems, and there can be some patients who have an important arterial and venous component to address, and they can be challenging patients. But overall, in people who have tissue loss and arterial disease, our main algorithm, and I think most places do this, first focus on draining any infection that's present, and we do that by a wide debridement. So then what next? In terms of people who have either a non-healing dry wound or have been drained from any foot sepsis. And I see some questions coming up. Let me I'll go through this quickly. I'll try to go through it quickly, and then maybe go through some of these questions at the end. We then evaluate the patient for the main two categories of management: primary amputation versus revascularization. And we are very aggressive with revascularization, but not all patients are candidates for revascularization. There are some patients that might be better off with primary amputation. Some of the factors that we consider, there's several. First, things related to the foot, the extent of necrosis, the pedal circulation. If somebody has such an extensive foot wound that even if we were able to improve blood supply, even if that would fail to restore a weight-bearing surface to their foot, then sometimes the leg just can't be saved. Limb considerations also, again, extent of necrosis, pedal circulation. I guess I get some overlap there. Patient considerations, and then functional status is really probably one of the most important ones. People who are ambulatory beforehand do quite well after revascularization. For the most part, they will remain ambulatory, and likewise, people who are living independently, living at home, living in the community, who undergo revascularization, their likelihood of returning home eventually is quite high. It's on the order of 95%. People who are non-ambulatory, we not infrequently see patients from a nursing home who present with they've had a chronic ulcer that at some point led to gangrene of the leg. The patients who are not ambulatory, debilitated because of, let's say, hemiplegia from a previous stroke or some other problem that has left them with really no functional capacity. Those are patients who really don't stand to benefit much from aggressive revascularization. Those patients, there's not many patients like that. Most patients would benefit from revascularization, but that is one of the important considerations. Also, social consideration, the ability to have some support at home during any recovery phase is something to consider. Cost and cost of effectiveness, that's something that I personally am looking into, we're looking into in our center, cost effectiveness of different options. And just in brief, let me just say that primary amputation is not a cost-effective option for treatment of these patients. But in general, just consider some of these factors when deciding divided between primary amputation and revascularization, but be aggressive about revascularization. How is it done? Again, two main categories of treatment: surgical revascularization and endovascular revascularization. We will not talk about the technique because, again, you guys, I'm sure know a lot about these techniques. Now, in contrast to patients with claudication, patients with tissue loss are patients that we try to get inline flow to the foot. What does that refer to? That refers to direct flow through anatomic named vessels all the way from the aorta down to the foot, not collateral flow, inline flow all the way to the ankle and the foot. And we do that frequently with endovascular intervention. We do that in people who are not candidates for endovascular intervention with bypass. This is the main goal for patients with tissue loss. Now, rest pain, and we didn't spend too much time talking about rest pain, but for rest pain, the natural history of rest pain is probably not quite as bad as patients with tissue loss. And I say probably because there's not great data out there to describe their natural history, but it's not quite as bad. For patients who have rest pain, there's no real clear consensus on does inline flow, is that necessary, or is it treating just inflow alone or single level disease alone, is that sufficient? That works in a large number of patients, but I think it's kind of put on here dealer's choice because there's no clear consensus on it. I think people use some judgment in terms of if somebody has some mild iliac disease and they have an occluded SFA and they have rest pain, then it might make some sense to treat iliac disease and do an SFA intervention of some sort. Whereas if they have an occluded common femoral and an occluded SFA and iliac disease, then I think there'd be a lot more yardage gained by addressing the iliac disease and common femoral disease. So dealer's choice in essence. This I won't go through in the interest of time. I won't really go through this too much. Let me just say this: there's some thought that angioplasty may not provide as much of an increase in the oxygen delivery to the foot as bypass, but there's some conflicting data on this, and at least one group has shown that successful angioplasty can be as good in terms of increasing the TCPO2 or increasing ABI as a bypass. Results of revascularization are good, and in terms of this is from bypass. In terms of endovascular versus open, you guys are probably familiar with the Basel trial, and that's really the best quality data that we have that's out there. And just in brief, basically what it shows is that the amputation-free survival in patients who were treated with an endovascular first strategy versus a surgery-first strategy, the outcome was equivalent. So both are good options. Both are good options for all comers, and again, there's certain anatomic factors, certain patient characteristics that may lead you for an individual patient to go more with endovascular intervention, or maybe more for surgical intervention for other patients. But in general, it's very good data. There's some criticisms that are out there for Basel, and specifically whether or not the patient population that they studied over in the UK and Scotland, are they like the patients that we see here? There's some important differences. Most of the disease that they treated there was SFA disease, where I would say that in most of, I think most of our, here in our medical center, I think at most U.S. medical centers, our patient population is more like a prevent 3 patient population, in that it's more distal disease because it's a higher incidence of diabetes, higher incidence of end-stage renal disease. So there are some differences, but even still, the data that's out there from basal, the data that's out there from good quality, large observational studies suggest that endovascular and open surgical options are both equivalent. Both are very good options. So revascularization, and then following revascularization, you know, we work on this here, the soft tissue management. At some places, the vascular surgeon or vascular interventionalist focuses on the vascular work and then works with either podiatry, orthopedics, plastic surgery to do some of the soft tissue reconstruction. But it is important to tell patients that once they're done with getting their blood flow improved, they sometimes, but not always, are done. You know, some patients with a small ulcer will respond with just the revascularization and then some very minimal local wound care. But other patients, like this patient here, will need some further debridement of bone, debridement of soft tissue, sometimes skin grafting, sometimes some rotational flaps or other soft tissue management, but sometimes other things are needed. So I think I'm already probably talking too much and going over on time, but I'll just wrap things up there, and maybe we can just talk about some questions. So I see a couple questions out there, and if you guys have more questions, please write them in, or if you're on the telephone, then let me hear them. But let me try to go through some of them. For venous stasis ulcer, do we treat arterial disease first? Great question, and yet another area where there's a question mark. I think it's pretty clear that with patients with mild arterial disease, they can do fine with compression therapy, elevation at night, and their venous ulcers will very often resolve. Conversely, patients with very bad arterial disease, we try to avoid compression stockings on those patients. The question is, you know, how bad, how low can the ABI be, and the patient will still have a shot at having success in wearing a compression stocking, not having problems, and being able to heal up the wound. No one really knows. I think for the most part, right around an ABI of 0.6 or lower, 0.7, maybe even, people might be a little judicious in the use of compression stockings. But if there is a significant arterial component, then we try to treat the arterial component first, and then that gives you a lot of leeway in treating the venous disease with conservative management. Another question. For patients who are not good candidates for intervention, and it looks like the question is people who don't seem to be a good candidate for any kind of intervention, what are the options? There are a few options, and I would say that if you're aggressive about revascularization and you have a lot of options available to you, there are very few patients who are not candidates for revascularization because of anatomy. Two, comorbidities. These patients all have comorbidities, and a lot of them have very significant comorbidities like CHF, CAD. Yeah, I think in the past people had thought that a primary amputation might be safer for these patients. But we've actually worked on getting some good quality risk-adjusted data to compare If that is the case, and it looks like it's not the case, that primary amputation has at least as high a perioperative mortality rate as revascularization, either surgery or endo. So comorbidities should really not be, there's always exceptional cases, but that should not be a reason not to try revascularization. Anatomy too, again, if you're aggressive, that shouldn't be a contraindication. But there are some people out there who really just don't have any outflow. They have just a terrible anatomy, or they have just very, very bad comorbidities, and the anesthesiologist doesn't want to put them asleep, or no one's really interested in doing anything for the patient, or the patient refuses. The options. Jeremy wrote in the question about there's a few different devices out there. The Art Assist is one of them. Some of these compression devices that help try to augment flow to the foot. There's some data out there. They may be a good option. Somebody who's not a candidate for something else. There's other groups that have published on gene therapy of various sorts. Previously, there had been some studies looking at prostacyclin analogs and whether or not that helped. That is still in very preliminary. Gene therapy is still in very preliminary stages. I think the data on benefit from other molecular small molecules to help arterial flow was not convincing. So for the most part, the Art Assist may be one good option. Local wound care too is the other main option, other than primary amputation. And okay, so another question too about compartment syndrome. After treating somebody with acute limb ischemia, great question. Again, when to worry about it? Pretty much in all patients who present with acute limb ischemia are at risk for it. So always be attuned to it. To be a little bit more specific, when to really be very vigilant about it, or just in terms of being tactical, when to put somebody in the ICU so they can have frequent neuro checks to look for compartment syndrome, or sometimes too we'll actually do upfront fasciotomies, or at least fasciotomies where we incise the fascia and then close the skin, so the skin can be opened up at the bedside if people do develop signs of compartment syndrome. When to, how to be a little bit more specific. In general, the worse the symptoms, patients who present with pretty severe symptoms and signs of acute limb ischemia, take that as a sign of pretty profound, at least a profound change in their arterial blood flow. And those are the patients who are going to be at the most risk. People who have, the range of acute limb ischemia will range to some mild paresthesias, to people who have, pretty profound loss of motor function in their limb, complete paresthesia of their limb. It's those patients with pretty bad deficits that will be at pretty high risk. And then two, the people who have some background arterial disease, in this setting it may be somewhat protective for these patients. The very classic scenario is a normal young patient who has trauma, a popliteal disruption from knee dislocation. A guy with normal arterial circulation, can experience just a brief period of ischemia and then develop compartment syndrome. That's a patient that's definitely at risk as well. Another good question about angiosomes. The angiosome concept is something hopefully all you guys have heard about. It's a real interesting concept. We do try to revascularize based on trying to target the appropriate angiosome when possible. That's kind of a luxury. You know, if they have multiple tibial targets, either for endovascular intervention or for a distal target for a bypass, then the one that is in the appropriate angiosome would be the main target, should be the main target, because there is some good data out there from the center that has first described angiosomes in the setting of CLI, and now from other centers too, that if you can target that angiosome, the likelihood of achieving wound healing is higher. But if you can't, if that target vessel is not available, the outcomes are still pretty good. You know, it's on the order of 60% for a non-angiosome-specific revascularization versus 90% for an angiosome-specific revascularization. So if you have the choice of a few different tibial targets, then go to the angiosome when you can. But if you don't, it's still worth doing. You can still get some pretty good success rates. Good question about infrainguinal bypass for patients with claudication. Yeah, we definitely do it. Infrainguinal bypass with saphenous vein is good, and it's safe, and that is a good option in people. I think too, at our center and at most centers, more and more people are going endo as first-line therapy for infrainguinal disease, and in our center, people who have who either couldn't be recanalized or have been recanalized and failed. We do infrainguinal bypass. The availability of vein for a conduit is a really important thing. And if somebody doesn't have available vein, doing a bypass with PTFE in the setting of claudication is something that should be, I'll say this, should be carefully considered, because when a PTFE graft does occlude, it can actually leave the limb in worse off shape. It can take out some outflow and not just occlude the graft, but also take out some of the downstream outflow. So short answer is yes, we do it, good outcomes, but vein, the availability of saphenous vein is one of the main considerations there. Great, yeah. Thank you. Thank you guys for your time. Hopefully I didn't go too far.
Thank you very much, Dr. Barshes. Quite a very thorough and really great lecture. And thank you very much for taking time to answer all of our questions. I know we had a lot, and really some great information. Hopefully we can steal you again next year for
my pleasure. Yeah, I'd be happy to do it. Yeah.
All right. Any last questions from anyone out there? Okay.
Appreciate it.
Well, again, thank you very much, Dr. Barshes, and
okay.
thank you. All right.
Thank you.
We'll see you later.